All right, well, thank you so much to everyone for joining us for today's Doctor is In program on hospice and palliative care. We are joined today by Dr. Liz Spina, who is a hospice and palliative care fellow. Is that right? Did I get that right?
Yeah.
Formerly a fellow in geriatrics. So she did some of these presentations with us last year. And is now continuing on at Jefferson in hospice and palliative care. So we're very excited to have her back with us for another year of Doctors in programming. Hopefully we'll see you again after this, Liz. Before I turn it over to Dr. Spina, just a couple of things to review. So my name is David Griffith. I'm the Director of Programs and Outreach for the LGBT Elder Initiative at the William Wade Community Center. Doctors In is a partnership between the Elder Initiative and Jefferson, specifically the Department of Family and Community Medicine, which houses the Division of Geriatrics, and also the Jefferson Center for Urban Health. So we've been doing these Doctors In programs for the past couple of years to each month take a dive into a different health topic that affects LGBT communities as folks are getting older. And so having Jefferson doctors and geriatricians, medical professionals come in and share their information with us each month. For folks who have been with us before, you probably have the Zoom familiarity at this point, but just to review, you are able to ask questions at any time, either through the chat or through the Q&A feature. Things you put in the chat does have your name attached to it. If you want to send something privately that just the presenters will see, you can do that through the Q&A feature. And both of these options are going to be in the toolbar at the bottom of your Zoom screen. So when using the Q&A, there is an option to ask anonymously if you're asking anything more personal that you don't want your name attached to. But you can use either the Q&A or the chat. But again, just know in the chat your name does appear publicly. I'll be keeping an eye on both the chat and the Q&A, and we'll relay any questions as they come in to Dr. Spina. But with that, I'm gonna turn it over to Liz to get us started on today's topic. Take it away, Liz.
Thanks, David. It's really great to be back. So as he said, David said, I was a geriatric fellow last year, and now I'm a hospice and palliative medicine fellow this year. And so it's a perfect opportunity to kind of tell you what that really is and what we do in hospice and palliative medicine. So I'd like to start with a quote, and it's modified from myself. In the yellow, you can see I add illness because I think that's pertinent to today. But this quote is from Caitlin Doherty, who is a very witty and funny author, but she's also a mortician, and she really promotes normalizing conversation around death. And I think it's just a sentiment that I think we should talk about before entering this lecture is illness and death avoidance is not an individual failing, it's a cultural one. And facing illness and death is not for the faint-hearted. And I think that just goes to show how uncomfortable these conversations can be. But death and illness is a significant and an inevitable part of life. And talking and having conversations about what's really important to you and your beliefs around illness and death can be incredibly empowering, and it can really give you a sense of peace of mind. So I hope that this conversation today inspires you to have, to really look deeply into some of these topics and have some great conversations with loved ones and family members. So just to outline what we'll kind of go through today is we'll talk about a little bit of history of palliative care and hospice medicine, and we'll really define what each of them means, talk about some of their unique goals and means of delivery and what differentiates them and has them also very similar in many ways. We'll discuss some symptoms and diseases that may benefit from hospice care or palliative medicine. And then if we've got some time, we'll kind of talk about some ways to protect your wishes and leave some time for question and answers again at the end, but please feel free to ask questions or have comments throughout this lecture. And I do want to note that hospice care and palliative medicine are the terms that I'll be using, but they're no means bound to each other. So you may hear people say hospice medicine or palliative care, but for the purposes of today, I'll be just using hospice care and palliative medicine. So I'd like to talk about some of the beliefs of end of life that really kind of stemmed a lot of medicine and kind of what we think of today with palliative medicine. But the first, thoughts around relieving suffering probably came in the Paleolithic era, where there was a birth of animism, which is the belief that a spiritual world kind of impacts the world that we live in. And the idea that sickness and suffering was really inflicted on an individual from a spirit or a god, and ritual could kind of help alleviate some of that suffering. That, really was a transcending idea and really kind of transversed across many religions. Buddhism, there is Gautama Buddha, who was did the original teachings of Buddhism. And he really went on a quest to find a religion that would be able to alleviate suffering. And so there is a lot of religious sentiments about relieving suffering and taking care of those at the end of their lives. A lot of Western hospice and palliative medicine is bound close to the Christian church. There were many saints that devoted themselves to caring for soldiers, and we know in the original Christian wars back in the year 1000, there were many saints that had devoted themselves to caring for soldiers. And so this idea of caring for those who were ill and sick is deeply rooted in a lot of our societal norms, spiritual norms, cultural norms. And I like to just note that while a lot of our beliefs in end-of-life care and relieving of suffering have been influenced in Western society by Christianity, that's, it really is seen all throughout the world in Western and Eastern medicine. So what we think of when we hear of modern palliative care and hospice, this is really the mother of hospice and palliative medicine. This woman, her name is Dame Cicely Saunders, and she was a nurse who cared for people at the end of their lives. And she suffered from, unfortunately, her own medical ailments. So she ended up being a social worker, and she was really moved by caring for refugees. And she saw the amount of, care that can be really influential at the end of someone's life or in the moment of suffering. And she wasn't just a pioneer because she was influential in the spread of hospice and palliative medicine across Europe and into America, but also she was one of the first physicians. She ended up becoming a physician who used some of the oldest medications that we have and we still use today to alleviate some symptoms that someone might be experiencing from a serious illness. So are hospice and palliative medicine different? What are they? And they are different, but sort of. And I'll kind of talk to you a little bit about that. So palliative medicine, and I think this is important for me to really read off the slide, but I apologize. It's a specialized care for people with serious illness. And the goal of this care is to improve quality of life, not just for that of that individual, but also their support system. So their loved ones, their families, their friends. And that support would be to help face burden that's associated with that illness. And that burden that someone may be experiencing from illness can be as symptoms, it can be physical symptoms, psychological symptoms, social symptoms, or spiritual symptoms. And it can also be the burden of kind of making decisions in this crazy chaos of a medical system that we have. It's really encompassed by an interdisciplinary team. So a palliative medicine team would have not just a physician, but also a nurse and a social worker, potentially a chaplain, who can really create a comprehensive and individual care plan for someone that supports relieving the burden of serious illness. Their goal, again, is to optimize quality of life by mitigating suffering at all stages of disease. And I think it's important to note that this is an additive layer of support and it is not in substitute of conventional medicine. So for an example, if someone were to develop cancer who wanted to undergo chemotherapy and radiation and potentially surgery, some of that therapy might expose some symptoms, whether it's pain or discomfort or shortness of breath, or just the burden emotionally that you go through when you have a diagnosis like that. And so the palliative team will be a supportive team in that, and they'll help kind of alleviate that pain that someone might experience. But it's not in substitution of going forth with treatments like chemo and radiation. Hospice care is a subset of palliative care. It's a care service that emphasizes symptom control and emotional support for the patient and family, but it recognizes that this is a terminal illness. Again, it is an interdisciplinary team, so it is a very comprehensive approach where you have support from a physician, a social worker, a nurse, a chaplain, and the goal is still to improve quality of life by mitigating suffering. But often when someone enters hospice care, they're discontinuing preventative therapy and curative treatment, and they're transitioning their care to comfort and symptom relief only. And it's really appropriate for people with a limited life expectancy. So I think this is a nice kind of way to see that hospice and palliative medicine share a lot of similarities, but they do have some unique attributes about them. So they both promote quality of life, improved quality of life, and symptom relief. They both provide that comprehensive support, and they're really patient and individually driven. But palliative medicine is really for all stages of disease and all diseases that might need the support. And it really promotes continuing treatment, including the ones with intention to cure, versus hospice is for people with advanced disease and typically less than 6 months to live. Generally, patients stop treatments that are preventative or curative, and care is no longer to lengthen the life as much it is to improve that life that is left. So this diagram kind of shows how potentially someone's trajectory with a serious illness may look. So the lower left-hand corner is when someone might be diagnosed with a serious illness. At the top, you'll see, curative restorative care. That's things like, medications, surgeries, different treatments, different types of therapies, and then palliative care. And you see that they kind of harmoniously exist together. And this line is kind of an individual's trajectory through time. And you might see that they need a little bit more support from palliative care at time, and they might need a little bit more support from curative or restorative, but there's a nice harmonious balance between the two. The goal is that someone might find a cure. They might be cured and or stabilized with the condition, and which I'll talk about in a little bit. It's a term that we like to use called survivorship. But for some, that's not the case, and not everything that we can, while we're hopeful, will cure serious illness. Not everything that we can do in medicine will provide a cure. And so for some people, they might find themselves at the end of life in which you transition more to symptom relief only. And that's where palliative care is the primary treatment, is really just to alleviate suffering and symptoms. So like I alluded to, palliative medicine really promotes improvement in quality of life. People who enroll in palliative medicine typically have less anxiety and depression. They have an improved spiritual well-being and are more likely to have their wishes followed through. Most individuals express that they prefer to die at home. And so those who enroll in palliative medicine and hospice are more likely to die in their preferred place. I think this is a nice graph to kind of represent an important point. This was from a study, and I won't be quizzing anyone on this or asking anyone to interpret it, but this is from a study where they looked at individuals who had a certain type of lung cancer. And they found that even with conventional treatment and standard care, those who had an additive layer of support with palliative medicine had a prolonged survival. So they survived longer than those who did not have the support of palliative medicine. So who should see palliative medicine? Anyone with an illness leading to symptoms or difficult decision-making. We commonly think of people with cancer, but this is not exclusive to those diagnosed with cancer. We also take care of people with COPD, lung disease, heart failure, those with advanced kidney disease that might be facing the reality or decision of starting or continuing something like dialysis, those with progressive neurodegenerative diseases like ALS or Parkinson's disease, even Alzheimer's dementia, where we know that the symptoms of the disease will continue with time. Chronic infections, those with hepatitis or HIV. And then what a lot of people don't recognize is that we can help in static conditions too. Those where there is one event, but it's a profound event and it really changes how an individual lives their life. Things like a motor vehicle accident or a car accident that could potentially cause paralysis or disability. Someone who has a stroke who is suffering from disability, or a change in their ability to kind of communicate or think. And so palliative medicine can be helpful in those conditions that aren't necessarily progressive, but are really profound in the way that someone might live their life. So what are some common symptoms that are treated under palliative medicine? Pain is a big one. A lot of individuals will experience pain from the certain types of ailments that they're experiencing, but also the treatments that they might be receiving for those illnesses. Shortness of breath or respiratory symptoms, the emotional effects of going through a serious illness, depression, anxiety, nausea and vomiting, eating problems, whether that's problems with swallowing or appetite, or just lack of appetite at all, chronic fatigue, and then agitation and confusion. A really important tenet that palliative medicine has is a term that we like to say is shared decision making. It's something that we really emphasize, and I think is really important for anyone who's making a difficult decision, and anyone who's making a decision where there's not just one right answer or one right treatment course. And I think we're starting to change directions in which medicine is thought of. In the past, we had this very paternalistic approach. We would tell patients, based on my judgment, this is what you should do. And that's not what is always beneficial. That's a very one-sided conversation. So shared decision-making is really a bi-directional flow of conversation between an individual and the clinician. And palliative care, it's kind of our, it's our specialty. That's what we really do well. And what the patient and or the individual needs to, express is what is really important to them, what, their hopes, their feelings are about certain interventions, what their goals are by going forth with any treatments. And the clinician should be able to see who they are as an individual, see what their goals are, and based on their clinical experience, match up a treatment plan that would be, that would be reflective of that individual. And so it is really a shared conversation. And it's something that palliative care really emphasizes. And so when someone has a difficult time making a decision of whether or not they would like to undergo, chemo or surgery or whatever the case is, palliative care can really help navigate an individual and their loved ones through that decision. So what does palliative medicine really look like in the field? There are three types of palliative medicine we in our clinical setting. There's home palliative medicine, there's palliative medicine in the hospital, and then there's palliative medicine in clinics. So in the home, and I like to use this icon because we're in Philadelphia, and so it's a row home, but it's generally nursing run. It's generally nursing run. So an individual would have a nurse that would come out to their home, kind of as needed. And it's really dependent on the palliative service and the team that someone would, create a relationship with. That could be, once a week, it could be once a month, it could be kind of as needed. But the nurse would come out to the home. And the hope is that the home service would really alleviate some of the burden of going back and forth to a clinic, and prevent potentially needing to go to the hospital. Their goal on home hospice is really to help with symptom relief, and have ongoing conversation about end of life care. In the hospital, it's really if you're needed, if someone is hospitalized and they need to have that acute care, it's a team and it's really driven by providers. So a nurse, practitioner, a physician assistant, or a doctor. But they're also supported by social workers and chaplains, and it's generally a bigger team, but it's mostly driven by providers who would kind of come and support and talk about symptom relief or decision making. Their relationship with that individual kind of stays in during the hospital stay and doesn't extend, after it, unless there is, a need for it. They can help with discharge planning, if there's conversation of where someone wants to go, whether they want to go home or rehab. Some people decide to enroll in hospice, and so they can kind of help go through all of the options on how to best find the discharge plan that would best suit that individual. And they can see someone up to daily or even multiple times a day. And then there's also office palliative care, which is kind of a continued care. It's in a clinic. It's, again, provider driven, but also supported by an interdisciplinary team. And its goal is for symptom relief, decision making, and particular kind of decision making with advanced care planning, which I'll talk about briefly at the end, which is the idea of having some conversation about what's important to that individual when making future decisions about their care, and then counseling and support. So, as I mentioned earlier, survivorship is a term that we used, and it's generally applicable to cancer patients, but not exclusive. But it's the idea that after an individual completes the treatment or completes the procedure, or whatever the scenario is, and finds themselves in a remission state, that's generally can be pretty jarring for someone. They can be used to going to appointment after appointment, hospitalization after hospitalization, They can become dependent on some of the medications, and there's a very large swing in someone's life when that can happen. And so palliative care can really help bridge that transition, whether it's weaning off of certain medications or providing emotional support during that time. But that can be really jarring for people, and it's important for providers to bridge that transition. So going back to hospice care, what does hospice care look like? Hospice care is also generally in three settings. There's home hospice, a hospice unit, and a nursing facility with hospice support. So a home hospice is under hospice service, where there are an individual goes back to their home or residence or a loved one's residence. And the majority of their care is supported by friends and family. The caregivers that goes into doing routine, cleaning and bathing and administering medications, and a lot of care is relied on by the friends and family. There are supportive secondary care. So there's home health aides, there's hospice aides, there's nurses and chaplains and social work, but they, are supportive multiple times during a week, but by far the family and friends are the most important to provide care to that individual on home hospice. There is nursing availability 24/7 by phone, and they can increase the amount of times that they come to the home and provide support based on, what is needed by that individual. And that home hospice would be eligible for something called respite care, which I'll talk about shortly. There's an inpatient hospice unit, which is generally an independent facility or within a hospital, or a very quiet section of the hospital and a remote area. And when someone would go to an inpatient unit, the majority of their care is followed through by nurses. They would do things like daily care, washing up, feeding if needed, medication administration. They also have oversight by a physician while they're in an inpatient unit. But you have to qualify for an inpatient unit. And so not everyone would be eligible to stay at a hospice unit, but it's really helpful for those who have ongoing symptoms that need close observation, or someone who needs to have ongoing procedures to kind of help alleviate symptoms. They are also supported by home health aides, hospice aides, chaplains, social workers, and nurses. And they're, provided 24-hour support around the clock. There's a nurse with that individual. Respite care is essentially managed in an inpatient unit. And so those individuals don't really kind of qualify underneath the need for respite care. And then a nursing facility is kind of the last, large clinical setting in which hospice can be accommodated under. And again, most of the care is followed through by nurses, and it's underneath a skilled nursing facility. So an individual typically needs to have either a relationship with that skilled nursing facility before enrolling in hospice, or the hospice can kind of help to create a relationship with a nursing facility. So what is respite care? Respite care is temporary care provided to an individual, and it's really intended for a caregiver, for friends or family, to give them some support so that they can do the things that they need to do, whether it's undergo a surgery or a hospitalization or go on a vacation or just recharge, because being a caregiver can be very emotionally and physically demanding, and it's really important that that caregiver can have a moment where they have some relief. And so respite care can provide some of that relief. That individual that is enrolled in hospice would go to an inpatient unit or a nursing facility where they would receive that 24-hour care for about 5 days in length. And then the hope would be that they would return back to home hospice to continue, receiving care from the people that they love and have a relationship with. So how do I pay for hospice service? It's covered. So Medicare Part A, Medicaid, and private insurances essentially cover hospice in its entirety. There are a lot of, sections of Medicaid and Medicare Medicare that if you don't have a supplementary, there can be a financial cost, but hospice is not one of them. And many hospices have what's called charity care, where they will either cover the costs entirely for those who do not have any Medicare, Medicaid, or private insurance, or can provide the care at a very low cost. And so there are a lot of financial support for getting hospice services. So what is covered under hospice? Not only is it just the support of the providers and the nurses and the social workers, but it can also be medical equipment and supplies, whether that's a hospital bed or oxygen or, need for certain procedures, which I'll talk about in a second, symptom relief medications and treatments. So, if you need to have certain intervention that would provide symptom relief, hospice will cover that. Home health aides. So home health aides will be covered under hospice. They generally will recruit a number of home health aides either through supplementary services or underneath their own service, but they don't always offer as many hours as that family really needs. And so again, the home health aides are there to bolster, but not replace the amount of care that the family will be providing. And then spiritual grief counseling for that individual and family. And I think it's important to note that the spiritual grief and counseling for that individual and family extends not just during that period that person is on hospice, but even after death. The family is supported by that hospice agency for up to 13 months after, or longer, really, if needed. And so there is a continuity of care for not just that person, but also for their loved ones. Some things that aren't covered under hospice service is medications that don't provide symptom relief. And that's why there needs to be often a transition of medications that won't that will, just extend life, but not necessarily provide symptom relief. And so those medications could potentially undergo Medicare Part D or someone's primary insurance, and then room and board if someone stays at a nursing facility or stays at an inpatient unit for an extended period of time, which I don't want to go into too much because there's a lot of nuances of it. But room and board under a nursing facility would need to be covered under another supplemental. So generally those who have a nursing facility either pay for it out of pocket, which can be expensive, or have Medicaid. So why would someone choose hospice? It's an individual decision, and it can be a really difficult decision to make. And it's a different care path. And I really want to emphasize that it's not giving up. It's not a dichotomous type of medical plan. It's not all or nothing. There is still care that's being received. It's just choosing to live as fully and comfortably as possible. It also provides a lot of support to that individual and their family and loved ones. So again, some more graphs, but I won't harp on them too much, but I think there's some important points. As you can see, this graph shows the year 2000 and 2010. And the bars are kind of the number of individuals or the percent of individuals that are enrolled in hospice in those 2 years. And we see that the majority of people that are enrolled in hospice are enrolled for a very short period of time, meaning they don't get the full support that they are eligible for in the last 6 months of life. Most individuals enroll in hospice in the last 1 to 2 weeks of their life. And so us as providers, we're missing the gap into when we are, fully supporting that individual. And it's important for us to find an appropriate time and have those ongoing conversations so that we can get someone supported for the full 6 months that they really need it. And then this graph, I think, is important because it shows that not only is hospice utilization going up with time, we've been seeing more and more individuals receiving the benefits of hospice, but also that the variety of people who are using hospice is also going up. So it's not just individuals with a cancer diagnosis, but it's also people with progressive neurological diseases like Alzheimer's disease, lung disease, kidney disease, stroke. And so it is not a service that is just for cancer patients. It's for any individual that needs that support and is at the end of their life. So can you still go to the hospital on hospice? The answer is yes. If there are uncontrolled symptoms that your hospice team really needs to manage in the hospital, if they need another provider expertise or they need a certain surgical intervention to kind of manage those symptoms, that hospice team would arrange for that individual to go to the hospital. For example, if someone had a terminal cancer but was living at home and walking around and then fell and had a hip fracture, hospice would still cover it for that individual to go and potentially get their hip fixed, because the symptom relief for that hip would really add to their quality of life. And the hope is that that individual would continue to be able to ambulate. This can be very tricky, and I don't want to say that's this right answer for everyone. And I think that hospice would have ongoing conversation of whether or not a hospitalization would really be beneficial. But the answer in short is yes. If the hospice feels like a hospitalization would not benefit that individual, and that individual and or their loved ones still want them to go to the hospital, someone can revoke their hospice service and go to the hospital. And so once you're enrolled in hospice, it's not binding. There is still very much autonomy and freedom to change that decision if you need to. So how hospice helps, I think symptoms are relieved, there's better pain control, there's higher quality of care. There are all of those supports that I had mentioned. But what's unique and interesting is that there's a lot of individuals who enroll in hospice who actually live longer than compared to individuals who don't enroll in hospice. And I think that goes to show that not everything that we do in medicine is beneficial at every point in someone's life. And so when we get to the end of our lives, sometimes aggressive care can be more harmful than helpful. And hospice can kind of help switch the gears and have someone really focus on the quality of the life that they do have left, which may inevitably lengthen their life. So what if you're interested in hospice for yourself or a loved one? You can ask a provider about eligibility. Usually that's a primary care doctor or a secondary doctor specialist like an oncologist or a cardiologist, to see if they think that you could potentially be eligible or your loved one would be eligible for hospice. The next step would be to choose a hospice or a preferred site of care, whether you would want that individual to go a home-on-home hospice, whether the amount of care might be too much and for a family to manage, and they might need support from a 24-hour nurse, in which then an inpatient unit or a nursing facility might be more appropriate. The next would be to undergo an evaluation by the team. Again, it's an interdisciplinary team, so it would be the nurse, the social worker, the chaplain, to determine a really comprehensive care plan. Let's see how much time I have. I guess, are there any questions that popped up, David?
So I wanted to add just one question on that last piece. So what sort of goes into choosing a hospice agency? So on the patient side, are they, or I guess actually I would say on the provider side, are you referring folks to certain agencies, or is it sort of expected that your patient is going to be doing the research to decide this is the agency I want to work with, that sort of thing?
Right, yeah, that's a great question. I think there are a lot of hospice agencies, at least here in Philadelphia. There are a number of them. And so we, as a provider that might be referring someone to hospice agency, I like to give the freedom if that family has had a relationship with a prior hospice or experience, or has heard, good things about a certain hospice, and would be interested in that particular hospice. It is not, solely a responsibility of that individual. If they have had a difficult time, or they aren't familiar with the hospices in the area, we as a provider can make a recommendation based on your needs or that individual's needs. Also, location, what would be convenient for family and loved ones. And so it can be a choice by that individual or family, but it also can be, guided by the provider. And so it's, a two-way street. Again, some shared decision making in that one, and choosing a hospice.
And then follow up to that. So if someone is not happy with the type of services they're getting, how hard is it to change a hospice agency?
That's also a great question. It's not hard to change hospice agencies. And if you are unhappy with a hospice service, I think what would be really important is to go up the chain, meaning convey that to not just the health aides that come to the home or the nurses that come to the home, but also the team physician. So there's a physician that overlooks all patients, whether it's in the inpatient unit or whether it's at home hospice or a nursing home, making sure that they know what is the issue to see if that can be rectified. And then there's even more support above that. So really going, above and beyond to advocate for yourself to see if that hospice can accommodate the need. I know that's not always an easy thing to do when, facing a very difficult time and having a loved one or potentially yourself being on the end of your life or their end of their life and having to advocate. But there are a lot of layers of support within a hospice. But if you are, even after, if you are at the end of your experience and you don't want to go forth with this hospice anymore, you would say that you want to terminate your services with them. They generally will kind of come talk to you a little bit more and see if they can rectify the situation. And if not, you just sign the paper and terminate the relationship, and then you enroll in another hospice. And that can be done very quickly. It's not a difficult transition to make. But my hope is that, you could find a common ground, and hopefully that they would be able to provide, the goal of hospice is really to provide as much support as possible. And so I hope that hospice would try to do that for them.
Great, thank you. And we did just get another question come in. So how does someone know when they need hospice or when their loved one needs hospice? So I know you mentioned there's sort of some clinical eligibility criteria, but I think also just for the individual, what should they be thinking about of when to start thinking about hospice for themselves or for a loved one?
Yeah. So hospice it can be really tricky. It can be tricky. But I think when one commonality of people who undergo the transition onto hospice is when we start to think about less than 6 months of life. And that can be really hard for someone to identify. But I think when you have a great deal of symptom burden, maybe multiple hospitalizations in and out of the hospital multiple times, um, are really kind of faced with a fork in the road of difficult medical decisions to make, um, whether it's limited treatment, treatment failure, or treatment adversity, whether or not it's a choice to discontinue treatments too. Um, I think that should be a conversation with that individual and the provider that they're asking if they're even eligible for hospice. But I think if you're starting to see multiple hospitalizations, a lot of symptom burden from an illness, or there's treatment limitations, I think those would be big themes that potentially this person could be eligible for hospice.
Great, thank you. Just a reminder, folks, feel free to get your questions in through the Q&A or through the chat. But for now, Liz, why don't you can keep going with this, the next slides.
Right. So I just really wanted to briefly touch on this. When we talk about the end of life care, it's really important that we kind of protect ourselves, because there are a lot of automatic things that physicians and providers will do to prolong someone's life, but that might not necessarily be in line with what that person would want. And so it's really important to protect yourself by finding what we call a surrogate decision maker. So if for some reason you are unable to talk or make decisions, talk to a provider and make decisions, who would you want to make those decisions for you in terms of medical care? And that would be a surrogate decision maker. It's a person who can make healthcare decisions for you if you're not able to make them for yourselves. It's also known as, and you might hear terminology of healthcare agent, healthcare proxy, or surrogate. A medical decision maker should be someone that's 18 years or older, but really can talk to you about your wishes and who you feel comfortable having those conversations with, who really understands you, and who would be dependable to see that your wishes are followed through, and who you trust also, really importantly, with your medical information. Someone who would be able to advocate for you, isn't afraid to ask questions and speak up for your wishes. And it shouldn't be a doctor or someone who works at a hospital or clinic unless they're familiar, or they're a family member or very close friend. If you don't choose a medical decision maker, a person would be appointed to you under Pennsylvania law. And that can be tricky because that person doesn't know you as an individual, and they don't know, your wishes or your goals. And so that individual might not choose medical decisions that are in line with what you would truly want. And so that's why it's incredibly important for you to identify someone who would be able to make those decisions for you. It's really difficult to kind of talk about what's important to you, and what you would like the end of your life to look like. It's a really sensitive conversation, and it can also be really difficult to define because there are so many unknowns and impossible to foresee circumstances of an individual's healthcare, that it's important to talk about importances to you on a more broad level. Really, what's important in life to you, what is the goals of your healthcare, not necessarily, would you want some very specific intervention, because that can be, difficult to really foresee. Choices should be based on personal values, preferences, and discussion with your loved ones. And this really can help not just you and empower you, but it also can provide a sense of relief to those who will have to make decisions for you or who may be making decisions for you, because it can be really difficult to do that. And so if you clearly define what's important to you, that really relieves that decision maker of some, potentially gray areas. I think it's really important to comment that end of life planning for LGBTQAI plus individuals has not always been easy. I think with marriage now extending to all people, it's really a kind of added a protective layer to end of life planning. But it always has not been that way. And so there has been a lot of discrepancy in end of life care for LGBTQIA people. And it's really important to support yourselves and, protect yourselves. And so relying on an individual to make decisions for you who you trust is incredibly important. Because if that responsibility falls onto someone who you don't trust, there can be, whether it's a transgender individual who their gender is no longer, affirmed at the end of life, would be awful. And then our laws have not always supported chosen families and really kind of look at birth families. And I think that's a disservice to a lot of individuals, because often chosen families are far closer than our birth families. And so I think it's really important that you protect yourselves and we protect ourselves. And by going to, whether it's a lawyer to do a living will, talking to your physician or doctor to do an advanced care planning where you define who your surrogate decision maker would be, and really advocate for yourself. These are some resources. There's getpalliativecare.org right for you, which is a great website that kind of goes through what palliative care looks like, and a bunch of different stories of individuals who have been supported by palliative care. There's a cancer information specifically for LGBT palliative care and community. And then there's 5 Wishes, which is an advanced care planning, which kind of goes through what a surrogate decision maker you would want to choose. And then also goes through certain medical circumstances where it helps at least give an outline for a flow of conversation for you and that person that you choose as your surrogate decision maker. After you really define it, who you would want to make medical decisions for you and what's important, I think it's really important for you to relay that information to all of your loved ones who would be supporting you, and your physician, and anyone else that's really important in your life.
Had another question come in, Liz, on the surrogate decision making. So would the surrogate be would the surrogate be included in the patient's decision making process if the patient is still able to make those decisions, but the patient wishes for them to be there or to be included? So I think basically is the healthcare proxy only coming in when the person can no longer make decisions for themselves, or can the healthcare proxy be there as part of that shared decision making process?
It can be whatever you want to make of it. So if you don't want that shared decision maker, or the surrogate decision maker, to be at all of the medical appointments, not participating in that shared decision making between you and the physician, then you don't have to have them there. But if you do want them there, that can really help bolster their advocacy and their involvement and their understanding of the situation. And so I think you can do either. If that individual would not be making medical decisions for you unless you gave them permission to, or you were unable to make decisions on your own. So it's really not going to override your word.
Great. If other folks have questions, please feel free to get those in the chat or in the Q&A. One more that I had, Liz, and I think it's just an important point to reinforce, is that when you're talking about family, that this can include chosen families, families of choice, support networks. So I'm wondering if you can just talk a little bit about what that can look like. How is the hospice profession getting towards these more inclusive understandings of families and care networks?
Gosh, I think that's an important point. I think there is a fear that chosen families will be not recognized as families. And, they are absolutely families. I think hospice as a whole is becoming more cognizant of, the idea of chosen families. I hate to use the word chosen sometimes because it's family. And so that support that is provided, especially that emotional support that's provided by the hospice service, doesn't just extend to birth families. It also extends to all families. And even that 13-month out, they still can provide support to chosen families.
So that includes some like the bereavement supports after someone's passing.
Yes, bereavement support. Yep, thank you. So I think hospice as a whole is really becoming aware of that and is shifting their tune and really supportive of any loved one that's involved with someone's passing.
Great, thank you. Any last questions from folks before we adjourn here? Feel free to get those in. I know these are obviously heavy topics, and thank you, Liz, for talking through all of this and sort of breaking things down step by step. Because I think, as you said before, it's even as there are things that are difficult to talk about, being able to sort of plan and know what is out there and know what you want, so you can think about that now when hopefully someone is not in that sort of crisis mode of having to be faced with this decision while also navigating a severe health scare.
Yeah, absolutely. I think COVID really kind of scared a lot of people, and I think it's impacted the way we've looked at healthcare too. And hopefully that, I think, inspired a lot of people to have conversations that are difficult. And these conversations are uncomfortable, but they can be incredibly empowering. And I think they're really important to have. And if someone doesn't feel comfortable having those conversations, we can always ask their physician or provider to kind of talk to them about it, because they're experts in medicine. And so just know that you're not alone. There are resources for you.